Yeah, so good morning everybody. I'll be talking about this Glueless, Sutureless SFIL, which is basically a modification of the chariot technique, but I use a slightly different instruments. So an example of a 70-year-old male presented with surgical aphakia with, cataract surgery done 5 years back. So I start off with doing a toric marking, and then using a crescent knife, I make 2 incisions just parallel to each other at around 3 and 9 o'clock. So I don't cut the conjunctiva here, but if you feel uncomfortable and you cannot manage the bleeding, you can always cut the conjunctiva. Then I use Pricon 1.5 millimeter keratome to make the chariot tunnels. So that's how I do. I don't use a needle, but I use this keratome to make 2 parallel tunnels to each other. And I always do a vitrectomy, a complete vitrectomy. I put all 3 ports, do a proper anterior as well as a core vitrectomy. Yeah. So if you want, you can do a SICS wound, open up the tunnel, or if you want, you can just go in with your 3.2 millimeter keratome, and then through the cornea itself, you can put the 3-piece IOL. So I do a small superior section, do a proper anterior vitrectomy, remove off the remnants of the bag, and then I do a proper core vitrectomy, make sure no vitreous is there. I don't induce PVD, but I just do a proper core vitrectomy. And after the vitrectomy is completed, like Dr. Webb mentioned, always you should check the retinal periphery. So I check the retinal periphery, and I additionally I do 360 degrees endo laser, because problems with SFIL, one of the main problems which I have experienced during my fellowship is retinal detachments, and it's extremely difficult to manage once you have RDs happening due to secondary IOL. So I always do a 360 laser. And then I create a small aperture 1.5 mm from the limbus with a 24 gauge needle. So I don't do the X-nit, but some situations where the pupil is small, I do the X-nit technique. So once I open the wound, I use a 25 gauge Alcon max grip forceps, hold one end of the IOL, of the haptic of the IOL, and externalize it. And the second haptic, I just put it inside the vitreous cavity. And then using the same max grip forceps, using direct visualization, I just fish it out. Because once you have cleared off the vitreous, you're not having any problem with the vitreous being entangled in the haptic of the lens. So I just fish it out directly, and then I just insert it into both the tunnels which I created with the 1.5 mm keratome. Yeah, so using a McPherson's, you can just insert it into the keratome, and you can see that you can adjust holding the aptics. Just just wash, do a little bit of AC wash, because sometimes the SFILs you tend to have a little bit pigmentation, and then you can just cauterize and close, and then I remove all the 3 ports. So no sutures, no glue. If you want, you can make an SICS tunnel, or you can just go directly through the cornea itself using a foldable 3-piece lens. Yeah, so this is how a post-op day 1. He doesn't have a superior iris. There was a huge iris defect superiorly. And this is on the AIOCT. You can see the centered IOL and post-op day 1 fundus. And I always make sure to do a post-op day 1 OCT as well as follow-up OCT to see, because after you have done a core vitrectomy. Yeah, thank you.